There we go.
It says.
Let's try that again. Hello, everyone. I am so excited. It has been a while since we've done one of our NBC webinar series on these Wednesdays. So I am so excited to be here with Abigail Johnston and Dr. Amy Beumer to talk about all things pathology, how to understand the not just the lexicon and the language, but like all of the, I feel like this is gonna be like the Cliff Notes version of like what it is that we need to know when trying to decipher a pathology report, how we can have engaging conversations with our oncologists, what it means for those of us who can't wait to talk to our oncologist and we go into the patient portal because we just have to see and know right away. So thank you all for being here. I am going to turn it over to my esteemed friends and colleagues. And if you're joining us on social media, please, feel free to use the comments. We'll be monitoring the chat, and let's have a lot of fun tonight. Thank you for being here.
Thanks, Laura. So this particular presentation of how to read a pathology report is in partnership with Project Life, which is a virtual wellness house for the people living with metastatic breast cancer and their families by those of us living with metastatic breast cancer. And it came out of a wonderful science series that Dr. Beumer teaches, all called Spinning Science. All the information you never knew you needed to know about breast cancer. So we're very excited because this is the first spin-off of the Spinning Science series to continue the spinning metaphor there. So looking forward to biomarkers, which is coming soon. But we're starting with how to read a pathology report because this is probably one of the first technical kind of what the heck is this kind of reports you get when you're diagnosed with breast cancer. Comes after typically a tissue biopsy where they're trying to confirm what is going on with these rogue cells that are in our bodies. So while this is part of the MBC webinar series, people with early stage breast cancer get pathology reports too. So it's definitely something that's relevant to all of us who have had a biopsy and who get a pathology report, whether we wait for our doctors or whether we Google frantically trying to figure out what it is. So this particular presentation also was sponsored by, I'm going to say it wrong, Menarini, Stemline Menarini?
Yeah, Menarini.
Okay. There's way too many companies out there that I lose track of all the specifics.
I have a slide.
And of course, oh, good. That's good. And I'm sure you'll talk about how wonderful Dr. Lutzberg is at Yale, who also assisted with the presentation, fact-checked, double-checked, doctor-checked, all of the things that Amy's going to be sharing tonight. So also just have to give my disclaimer. Nothing that you will hear tonight is medical advice. You should not consider anything that is being discussed tonight as medical advice. Dr. Beumer is a PhD, has a PhD, but she is not a medical doctor. So even though she has lots of wonderful things to share, just have to throw in that disclaimer. Certainly, if you have questions about your specific pathology report, we will provide information about how to share some of those questions, field whatever questions we possibly can, but we'll also suggest that you talk to team. So with all of that, I will turn it over to Dr. Beumer, who has just started a new line of treatment. We give her extra grace tonight.
Oh, thank you so much. Thank you for the introduction. Thank you for having me. I'm super excited to be here talking about pathology reports and then hopefully come back and talk about biomarkers, although we will introduce them in this talk here. And thank you to everybody who submitted some questions beforehand. I'm probably not going to get to all of them, but we'll do our best. And I'm hoping that this, I just said, I had it. I had the slides. Oh, there they are. Okay. So, as Abigail said, this is in collaboration with Project Life. This is me when I had hair. I have a PhD, but mine's in my PhD's in biology. I'm not an oncologist. Thank you, Abigail. I'm not an oncologist. And my research was not in cancer, but I've pivoted a lot with advocacy, and I'm really happy to be here. The video that we will link you to is a shorter version of this. It's 15 minutes, and the transcript was reviewed by the wonderful Dr. Miriam Lusberg, who is an oncologist and researcher and chief of breast medical oncology at Yale. So not everything I say here, but definitely on the video. So there's three main takeaways that we want to get from this. The first is biopsies and the pathology report and some definitions. So what is a biopsy? This is the removal of tissue or cells to determine if they are diseased or not. All right, so we're basically, in our case, looking for cancer. Pathology, and anytime you see this O-L-O-G-Y, ology, it just means the study of. So pathology is the study of disease, right? And a pathology report is the results of the study of the tissue or cells removed. So it's basically a report about your disease. That's all it is. All right, so the next takeaway is we're going to talk about histology. So again, ology, study of, and histo is tissues. So your body is composed of cells, and these cells do different things, right? But the cells are also organized into like functional systems called tissues, and then the tissues are formed into organs like the breast, right? So it's just looking at a small portion of an organ. So we'll talk about invasive ductal carcinoma, invasive lobular carcinoma, inflammatory breast cancer, and metaplastic. Sorry, I can't see the bottom part of the slide, so apologies there. Finally, we'll talk about receptor status and biomarkers. So one of the really important things you can see on a pathology report is, are you estrogen receptor positive or negative, progesterone receptor, and what is the status of HER2? And we'll talk more about biomarkers and definition, really important. And these are molecules that help us understand and treat a disease, in our case, breast cancer. So one of the things that I think is important and can be helpful is every time you get a pathology report, maybe you write it down on a little worksheet. And so there are links provided, whether, I don't know exactly where they're going to be, but you will have links provided to you for a worksheet for pathology. This first one is from breastcancer.org. Really nice, mostly geared towards early breast cancer. And then I made one for Project Life, like kind of based on it, but with different and more expansive questions that are more relevant to metastatic or stage 4 breast cancer. And we're going to kind of work our way through these, and I'm going to show you examples of actually my pathology reports. So again, what is a biopsy? This is the removal of tissue or cells from the body in order to determine whether the tissue or cells are diseased or not, and to learn about the cancer itself. And there's different types of biopsies. So if you had an early stage tumor, if you have an early stage tumor in your breast, they'll do a needle biopsy generally. And this basically takes a little punch out of the tumor. But this can be done on metastatic sites as well. And you can see here, you're looking at a hip bone that is having a needle biopsy. All right. And there's other types. There's also a surgical biopsy. This is when a tumor is removed. So if you had a breast tumor removed or a mastectomy, this is also can be used as a surgical biopsy. If you have tumors removed from metastatic sites, this is a surgical biopsy as well. And this is a little bit more difficult because it's easy to confuse this type of liquid biopsy with like circulating tumor DNA, which is something we're going to talk about in biomarkers. But a liquid biopsy in this sense is more looking at the like what you're seeing here, which is fluid that can build up outside the lungs. So these are lungs, and this is fluid. And this sometimes happens in stage 4 breast cancer. In fact, this is how I was diagnosed. And this fluid can be pulled off, and it can be examined in a pathology report as well. All right. And if I'm going too quickly, let me know. I can kind of see the comments, and I know either Laura or Abigail will slow me down a little bit. Sorry that some of the pictures didn't come out very well. In fact, this one came out very wrongly when I did a little Canva to PowerPoint transition. But what you're looking at here, this is a breast. This is a tumor. And then you can see coming away from the breast, these lines, those are ducts. And then at the end, they look like little grape bunches kind of, or blobs. These are lobules. All right. So what we're trying to get at here is this little needle biopsy, which doesn't look like a needle biopsy now, goes into the tumor and you get this column. Kind of looks like, a pencil or a pen. And then the column is sliced really thin. And when you slice a column, you get circles. And these little circles of tissue from the tumor are placed on a slide. Then that slide is examined under a microscope by a medical pathologist. So this is just a person who works in the lab at a hospital or somewhere else and looks at these slides and looks at the tissue that is removed from the biopsy. Now, what we're going to talk about is the histology. So again, histology is the study of tissues. And when we talk about breast cancer, a lot of times we talk about histological type. And there are three main ones, but there are other besides this, just to keep that in mind. This is not an exhaustive list. The first is the most common. So this is what you would see looking under the microscope. And you can see a lot of purple here, but you'll see that the purple is organized in circles. And these circles are basically ducts that have been sliced, and you can see they're full of cells. And those are cancer cells that have filled the ducts and started to spill out. This type of cancer is known as invasive ductal carcinoma, or IDC. So you can see this on your pathology report. Sometimes they'll even say no special type, and that's code for invasive ductal carcinoma. Now, invasive lobular carcinoma looks different under the microscope. What you'll notice here is instead of round areas, you see sheets and sheets and sheets of cells, like linearly lined up, right? And this is very characteristic, or is characteristic, of invasive lobular carcinoma. This type of cancer grows differently and also appears differently on imaging, which we're not going to get into, but that's something to keep in mind. Finally, inflammatory breast cancer cannot be diagnosed only through histology. You do need doctors to look at like how the breast looks and some other symptoms, but a lot of times what you'll see is this is a lymph vessel. So your white blood cells are carried throughout your body in lymph vessels, as well as blood vessels, but that's what this clear is. And this is basically like inflammatory white blood cells all kind of moving into there. So kind of give you an idea of what this looks like. Not that you're all going to need to look at it, but just to give you an idea. Okay, so let's take a look. This is pathology report from my initial biopsy from my breast from 2017. And I'm going to show you a lot of different pathology reports because they do all look different. You do have to hunt and peck usually through them to find what you're looking for. But there are some basics that you should see. So the first, like, you should always make sure your name is on there. You want to make sure you're looking at your pathology report. There should be a date. So you can see the date collected was February 2017 when it was received, and date that the pathology was completed. So what we've talked about right now is just histological type. So let's go down and see if we can find where this is. Oh, there it is. So if you go down, can you see my pointer, Laura?
No,
you can't. Oh, that's not great. Whoops. Okay. All right. So if you kind of scroll down, you'll see something that says histological type. And it says invasive mammary carcinoma, mammary for breast, carcinoma for cancer of no special type. So that's code for ductal, not otherwise specified. So the cancer found here, the cancer found in my breast and in the metastatic sites is ductal carcinoma. And that's the histological type. And I am sorry you can't see my pointer. All right. So the next thing I want to talk about is tumor grade. And tumor grade is how cancer-like or aggressive the cells are. And sometimes we think of grade, we're like, higher grades are better. In this case, higher grades are not better. Higher grades mean that the cancer cells are more aggressive. And there's a lot going on this slide. But what I want to point out is that there are three pieces of information that go into assessing what the tumor grade is. The first is tubule formation. So a normal breast, a non-cancerous breast, should have very defined tubes going through it. And so you see these round open areas. Hey, that looks really nice. Those look like tubes. So that's a low score. Now a high score, it's just a mass of cells, right? That's a high score. That does not look normal. That is cancer-like, right? So they look to see the basic formation of the tissue, right? Then they also look at nuclear pleomorphism. What? So that's just saying how weird the nucleus is. So if you remember back to some maybe biology, you have your cells, and inside the middle of your cells is your nucleus. That's where your DNA is. And your nuclei in your breast and in the breast tissue should just be these dark dots. And they should be nice and they should all be the same shape and size. And if they are, that's a low score. That's great. And if there are all kinds of funky sizes and shapes, that's more cancer-like, more aggressive, and you get a higher score. And then the other thing they look at is mitotic figures. And mitotic or mitosis is cell division. So if there's not a lot of cell division, which is hard to, like, if you're not used to looking at slides, that's hard to tell, but it's rare in this, the first bottom left corner. And then the bottom right corner, there's a lot of cell replication going on. So if you think of cancer cell replication out of control, that makes sense, right? That's a high score. So you have a score basically from 3 to 9. And then they take that number, usually divide it by 3 to give you a grade, which goes from 1 to 3. So what the heck? What does this even look like on your on a pathology report? So this is sometimes called modified Bloom-Richardson-Nottingham grade. What you're really looking for is grade. And so mine was a grade 2. The total score was 6. So the tubule score was 3, like there were no tubes in there. The nuclear score was 2. They were kind of messed up. And the mitotic score was 1, not dividing very quickly. So if you add those up, you get 1, 2, 3, 4, 5, 6. Divide that by whatever, 3, and you get 2. So right in the middle. 3 would be most aggressive. 1 would be least aggressive. Okay, so before we move on to receptor status and biomarkers, there was a question that was submitted, I think, in the signups, and somebody wanted to know what T1A-N0 meant. T1A-N0. So when your tumor is removed in surgery, or whether you have a mastectomy, either way, they're going to look at the size of the tumor and they're going to give it a T score, basically. So T stands for tumor. 1 is saying it's small, less than 2 centimeters. 1A means between, I wrote this down, there it is, 0.1 to 0.5 centimeters. So very small, T1A. I actually was T1A too. And that goes from T1 to T2 to T3. 3 is the largest, right? And then N0, N stands for nodes. That's how many nodes had cancer in them. And so N0 means no nodes with cancer. So T1A N0, that's what that means. So I appreciate that. We aren't going to go through that. But if you're interested in looking up, there's a lot, American Cancer Society has a good explanation of T and N values in cancer staging. So, all right, so let's talk receptor status and biomarkers. In breast cancer, there are 3 receptors that are really important. And sorry, these came out pretty wonky too. But this, you're looking at a cell, this orange ball. The nucleus is like a darker peach color in the middle. The 3 receptors we're going to talk about are the estrogen receptor, which are the blue balls, and you can see they're inside the cell and inside the nucleus. The progesterone receptor, those are the black balls inside the cell and inside the nucleus. And HER2, that's the one that got pretty messed up in the transfer. But those are these green little L things that are on the outside of the cell, because HER2 is actually on the outside of the cell. Why are these important? They are important because they are linked to treatment. So in cancers that overexpress or have too much, well, I won't say too much, a lot of HER2 on the outside, they're HER2 positive. And like, who cares? Well, we care because there are treatments that are quite effective for HER2 positive cancers. And one of them is Herceptin, which is also known as trastuzumab. And Herceptin is an antibody. That's what we're showing here. And this antibody sticks to HER2. And that keeps HER2 from signaling the cell to grow and divide. So that's the importance of receptor status, because of its pairing with treatments that can be effective for your specific cancer, not just breast cancer in general. Okay, so let's talk a little bit more about biomarkers, because your receptors, ER, PR, HER2, are biomarkers. So these are molecules, in our case, these are proteins, that can help us characterize a disease, here breast cancer or metastatic breast cancer, in terms of response to treatment, right? diagnosis of the cancer, activity of the cancer, or even prognosis. So we can get a lot of information from different types of biomarkers, including receptor status. All right, so how does this work if you're into like, how would they do this in the lab? That's what we're going to show here. If you're like, I don't care how they're doing this in the lab, you can just like zone out for like 2 or 3 minutes. I totally get it. So what you have here is 3 slides. And these 3 slides could be from the same person from the same person, maybe different cores, whatever. Okay. Oh, these came out horribly. So sorry. So what you're looking at is up close. So if you went really close, oh, this is so bad. Hold on. Okay. I'm going to skip the more sciencey part and skip to the end. So this one, these slices, these biopsy slices are all ER positive. How they do this is they take an antibody to ER. And just like COVID antibodies stick to COVID, ER antibodies stick to the estrogen receptor. When they stick to the estrogen receptor, you can't see this under the microscope. So they use a brown stain to stick to the antibody. And so what you're looking at here is all these brown cells. And you're like, how do they get brown? Well, that's because they have the estrogen receptor and the antibody for the estrogen receptor, and then the brown color code on it. So all of these cells are estrogen receptor positive. Now, you can't do all these at the same time, so you'd have to wash your slide off and start again. So let's look at the progesterone receptor. Again, this is a slide from a biopsy. We use a different antibody that sticks to the progesterone receptor, and then the brown stain. And so anything that has any cell that has the progesterone receptor will stain dark. And you'll see, look at all these cells staining dark with the progesterone receptor. HER2, same idea, but the antibody is to HER2 specifically. So it only sticks to HER2, stain that brown. And what you'll see here is a little bit different because the cells are kind of outlined in brown or gold. That's because HER2 is on the outside of cells. So it actually looks a little bit different than ER and PR. And then, of course, we have this person looking at under the microscope, and she's going to help write up the report and say, what is going on here. Okay. Take a little drink here. I may be tearing through this a lot faster than I thought I would. So since I am tearing through it a little quickly, are there any questions that I'm missing in the comments or?
We have, thank you, Kathleen, for being here as well. And for everyone who's watching, I know, Kathleen, you just mentioned this is so awesome, loving it. I know I'm personally learning a lot. I always knew what my grade was, but not to know the 3 different ways that compiled that total score and then divisible by 3. So that's really helpful.
Awesome. Cool. Yeah, I actually just learned that when I was putting this together too. So there you go. Like a year ago. So learning things out all the time. So let's talk HER2. And speaking of learning things all the time and treatment changing and our understanding of the roles of our receptors, this is a really fast moving area. So on your report, you will see HER2 positive, low, negative. And how is this determined? So what you will see is an IHC score. An IHC, and I thought I had this on a previous slide, stands for immunohistochemistry. So IHC is this whole process of staining the slides with taking the antibody and sticking them to the receptor, and then adding the brown stain, and then looking at it under the microscope. And that process is just called IHC, or immunohistochemistry. On your pathology report, you should have an IHC score for HER2. If it is 0, your cancer is HER2 negative. It's pretty straightforward. All right, sorry that you can't see this. If your IHC score is 1+, your cancer is HER2 low. And that opens up treatment lines, especially in the metastatic setting, specifically in HER2, which is also known as trastuzumab deruxtecan. This is where it gets a little bit harder. And again, I'm sorry for the way this transferred, but if your IHC score is 2+, then you could either be HER2 low or HER2 positive. Not you, I'm sorry, your cancer, right? It could either be HER2 low or HER2 positive. And so they have to do another test. And this test is called the FISH test, or the ISH test. That stands for in situ hybridization. We're not going to go into it. too deeply. Well, we're not going to go into it at all. All you need to know is if the fish is negative, then your cancer is HER2 low. If fish is positive, then HER2 positive. All right. So the only one that's weird, again, is this IHC score 2+. They have to do another test, which again usually means you have to wait longer because they don't do the fish test unless you need it, because it's expensive, to be honest. It's time intensive and it's difficult. So then if you're fish negative, HER2 low, fish positive, HER2 positive. Okay. The last is IHC score of 3+. IHC score of 3+ is HER2 positive. All right. And so then that's, again, HER2 positive, Herceptin, Perjeta, a lot of really great drugs out there for it. HER2 low and HER2. There was just a study that came out at ASCO talking about HER2 ultra low, and showing that if you have more than 0 HER2, but less than 1+, so basically this whole area in here, then HER2 could also work for you. However, most places are not testing for ultra low. So you're still getting a 0 or 1+. So it's difficult to tell. I can tell you that Dana-Farber is doing that test. So if you're unsure and are looking for a second opinion, and there's a possibility maybe you are HER2 ultra low, that might be a place to check it out. I expect we'll be seeing more of that and getting more clarity in that area as well. Okay, so here's
Abigail.
Amy, I just wanted to ask too. So the HER2 low category, because I know there's still a question of whether it's a different subtype, right? That came about in, correct me if I'm wrong, 22, 23?
Yeah,
recent. 22.
Right. So when I was diagnosed in 2017, nobody knew anything about HER2 low. And so a lot of these specifics, +1, +2, those kinds of things, that's not on my pathology report. So I just wanted to point out that from 2017, if you had a biopsy prior to 22, most likely some of these categories are not going to show up. And so there is the possibility of getting the biopsy retested, even if you had a biopsy. They are required to bank your tissue, typically up to like 7 to 10 years. So if you're in that range, you might consider asking where your tumor blocks are. But I just wanted to throw that out there for those of us who were diagnosed prior to 2022. Some of this nomenclature is just doesn't show up.
No, that is an extremely good point, because and I think I might, well, as we go forward, I'll show you, but I was diagnosed initially in 2017 and they gave me an IHC score of 1+. So I can go back and say, okay, now I know that's HER2 low, but there was nothing they could do with it at the time. And so just not putting anything on there was an option at that point because it didn't mean anything. So such a good point.
I have a question also, while we're like kind of lingering on this HER2, and it's not on your slide. I know this isn't like medical advice, but just asking, have you come across HER2 status of like new? I know sometimes on pathologies we'll have the NEU or equivocal. And so do you have any background or information on that?
So HER2 and HER2 new, my understanding is they're the same thing. Okay. Yeah, they're equivalent. They're equivalent. Thanks for the backup on that too, Abigail. Appreciate it. Because especially in other cancers, sometimes it'll say HER2 new, NEU. And it took me a while to figure out that those were the same things. That's a great question. Thank you. I should throw that in there.
But just another confirmation, there is no consistency in terms of how various institutions are reporting these things out. Like there's not everyone use this form. That would be really nice. We should maybe do that. Like that should happen.
But
there may be
advocate for.
There may be a lot of variation. I mean, I've had biopsies done in and the reports look completely different. And it's a great also reminder that there's that express HER2 as well. Right. And so sometimes those pathology reports are going to look different also.
Yeah, no, that's a great point. And so this actually is a screenshot of another pathology report of mine that you'll notice looks completely different. than the first one. So there is no standard. So this is wherever I had this one, I don't even remember. Breast biomarker reporting template, metastatic adenocarcinoma involving liver. So this was from a liver biopsy about 8 months ago. And you'll see test performed, estrogen receptor status. Usually it'll say positive or negative. There is a newer category, especially with people who have triple negative breast cancer. If it's beneath, or if it's what is it? I think it's below 10%. Then, but greater than 0, they'll say it's HER2 low, or sorry, ER low, estrogen receptor low, and they're finding some success, I believe, with using targeted hormone therapies for that population as well. But here, so the status here is positive, greater than 10% of cells demonstrate positivity. And then it gives the more exact number, 11 to 20%. And then it gives you, oh, this is the test type, this is the antibody type, blah, blah, blah. We don't care. But what then we next care about is the progesterone receptor, positive at 3%. All right. And then we go down again, stuff we don't care about. And then we get HER2 by immunohistochemistry, negative, score of 0, right? So I was initially HER2 low, and ever since I've been metastatic, the cancer has been a HER2 0. And then again, there's more information at the bottom, just telling you more about the test. Because again, these are not geared towards us as patients. These are geared towards the MDs. However, I believe, and I know a lot of us, and maybe most of us believe that we should be able to read them too. I guess I'm preaching to the choir if you're already here. Okay, so let's look at another one. So this is from 2017. Antibody ER, you'll see it's set up totally differently. And it says, okay, antibody ER, over 95% strong, positive. PR, less than 1% moderate, it's negative. And then HER2 expression, negative, score 1+. What you'll also notice is that my ER is different, my PR is different, and my HER2 is different. So a really important point is that your receptor status can change over time. We'll talk more about that later, but I want you to keep that in mind. That's why it's important to have biopsies, particularly upon progression. Again, not an MD. This is just my opinion. All right. Oh, look at this. This one came out great, didn't it? All right. So other results you might find in a pathology report. So PD-L1, and so what this should say is PD-L1. And this is a protein that is found on some cancer cells. And we're not going to go into like, what does the protein do, but we'll talk about what it means, right? So because it's a protein found on some cancer cells, including breast cancer cells, it can be detected or found using immunohistochemistry. Same idea. Antibody sticks to PD-L1, brown stain sticks to antibody. Look at it under the microscope. Is it there? Is it not? Right? Now, why do we care about PD-L1? One of the reasons is it is a biomarker for treatment for an immunotherapy treatment called Keytruda or pembrolizumab. And that just means that people with cancers that are PD-L1 positive or breast cancers that are PD-L1 positive are more likely to respond to Keytruda/pembrolizumab. It also makes getting that drug easier because the insurance will look for that to approve that drug. All right, here's another one. This is the GATA protein. This is another protein found in almost all breast cancer cells. And this is one that they look for to determine if a distant site is metastatic from the breast, meaning, a breast metastasis, or is a new primary. So say I hope this never happens, but it does happen. You have breast cancer 5 years later, you have a scan because you're experiencing some pain, and they find a lesion maybe in your liver. And they're like, well, this could be a metastasis from the breast cancer, or it could be a new primary, it could be liver cancer. One of the things they can use to determine whether it's breast cancer is GATA. And so they'll stain for this protein. Same thing, antibody sticks to GATA, brown stain sticks to antibody. Look at it under the microscope, is it brown? So, and then this can help determine if the metastasis is from a breast primary. There are other tests they'll do as well, but this is one I've seen a lot of. All right. So other results, let's talk about Key 67. So we got So what is this again? This is a protein in tissues and cells that can be detected by IHC, again, immunohistochemistry. So Ki67 is found in the nucleus of cells. So this picture here on the right is a micrograph, which is basically a microscope photograph. And each of these little dots is a nucleus. Ki67 is in the nucleus. So there's an antibody to Ki67, only 6 to Ki67. And then there's a brown stain, same thing, 6 to that antibody. And then you look at it under the microscope. So IHC is really, really important. Immunohistochemistry is really important in pathology. So why do we look for Ki67? Well, not for treatments, but what this does help us understand is the behavior of the cancer. So high Ki67, over 30%, is associated with faster cell division, aka or also known as proliferation. And that means usually more aggressive, faster growing cancer. Again, so more cell division generally means quicker growth of the tumor. And you'll see Ki67, like I never had it done. Nobody had ever done it until my last biopsy. Sometimes they do it for early breast cancer. Sometimes they do it for advanced or metastatic. It just kind of depends on what they're looking for.
I think that's a really good question. I'm just looking at the chat as well, whether we're talking about Ki67 or on your previous slide with PDL1. The question is, what subtypes would look for PDL1? And
usually triple negative. That's usually triple negative breast cancer. Although, so in my case, we actually did just do a PDL1 test on my liver biopsy because the changing receptor status, like HER2 is 0, ER has decreased significantly. So is there some thought that the cancer is changing to become more like a triple negative breast cancer, acting more like triple negative and less like hormone receptor positive? So that's a great question. Yeah, I love that. And I think, Abigail made this point earlier, but I just want to say it again. You don't have to go back and get a whole nother biopsy to get fresh tissue for this IHC, for these kinds of stains. You can use old tissue from old biopsies. And that is really useful and really helpful. Okay.
I did just want to say, so the cancer in my body is hormone positive, but I am also PDL1 positive, which is unicorn type thing. But PDL1 status and your tumor mutational burden, which we may talk about as those are somewhat connected in that the molecular specialist that I've seen at MSK has said, even if you're PDL1 positive, be high. If you do see this PDL1 positive and you're hormone positive, very important to have those conversations with your doctor, but you may get a report that says you're eligible for pembrolizumab, even if maybe that would not be with your doctors, to just as you're talking about potential new lines of treatment, that sort of thing. But it is possible to be PDL1 positive and have a positive estrogen receptor.
No, totally. Yeah. And I think, it's important to check it. There are lots of different kind of genomic signatures, which is what Abigail was talking about with the tumor mutational burden. Another one is loss of heterozygosity, which there are a few, and we'll talk about those in the next one, I believe. Not in this one. We're not going to hit as heavy into the molecular side.
I love that we're already planning phase 2. So
right.
Great questions, you guys.
Okay. So we just talked about Ki67. And we also talked that receptor status can change over time. So cells are, cancer cells over time evolve. They evolve to thrive and grow. And when they do that, that leads to changes. And we can't always predict them. And most of the time we can't predict them. So getting those receptors retested upon progression is helpful. It's not always an option though, but it is something to discuss with your doctor, I think would be the important thing to say. Sorry, I'm trying to think Elena asked if we could repeat that. So receptor status can change over time because tumor cells are evolving, And it's important to talk to your doctor about getting repeat biopsies upon progression. So if you have progression and maybe with liver mets, I'm really stuck on liver mets because I have them, sorry, or lung mets or whatever, like if there is a possibility of going in there and getting a sample to test for receptor status, my thought is it's really important and you should discuss that with your doctor. But of course, there are risks to biopsies. So it's so important that you talk to your doctor about those risks as well. Great. Okay. So I want to talk a little bit about tumor heterogeneity. So tumors, right, the cancerous cells and all the other cells that are with them, and heterogeneity just means differences in like genetics and differences in receptors. So the receptor status can be different from the primary breast cancer and among different metastatic sites, right? So a liver tumor can be different from the breast tumor, can be different from a brain tumor, and in fact, many cases is different than a lung tumor. And I think that we are learning more and more that where the metastatic tumor is important to how it acts and how it responds to treatment. There was just a paper out talking about that in like liver versus lung and PD-L1 expression and response to immunotherapy. So, and it makes it difficult. I mean, it's interesting from a scientific standpoint, but from a response to treatment standpoint, it can be really difficult. Receptor status can also be different within a single tumor. So remember, if they're going to do like a needle biopsy, they're going to send a needle, which is this pencil, right, into the middle of your tumor or to the side or wherever they can get it safely. And they're going to come out with a little piece of that tumor, right? But that tumor is different in different places. So you're only getting like a snapshot in time and space in terms of receptors and what we'll talk about next time, genomics. So there are ways to add information to that, which we will talk about. If you've heard of ctDNA or liquid biopsies that take a blood draw and then can look at not your receptor status, but they can look at your genomics and see if you have some tumor mutations that have popped up. All right. So again, I just want to point out these two PDFs that we'll have linked for you. If I were, it's always like, do as I say, not as I do. If I were good, I would have one of these for each of my biopsies. And I think that can be helpful. The other thing you'll notice at the end of these is it says like genetic testing for inherited mutations and genomic testing for tumor markers. This we will discuss in the biomarkers. We are not going to just, it's too much time to try to fit all of that into an hour, even though I blew through this really quickly. But we'll talk more about that later. But you find this genetic testing for inherited mutations and genomic testing. Those will not be on, generally, I've never seen it happen, not on your pathology report that you get right after a biopsy. The genomic testing takes time, and the genetic testing is something you would do separately. All right. Okay. So if you have questions, feel free to reach out to me. You can find me at scienceresearch@projectlifembc.com. We're going to put a link to the YouTube video. So the YouTube video is on the Project Life, our wellness house. But that's only for MBC patients and caregivers, but it's also on YouTube and available to everybody, and can put in, I think we will have that for you as well.
Yeah, if you share things with me when this gets published, we can put all of the resources as part of the notes. So everyone who's watching tonight will have access, and we get the information out there.
Thank you. And that is all I have.
When you were talking about, and thank you for that incredible presentation, when you were talking about like the needle going into the cell, I always think of this. I don't know why I'm like obsessed with like pumpkin pie at like Thanksgiving, but like, when like the pumpkin pie has been like in the fridge for like a little too long, and there's that section that has a little bit of mold on it, but you want to like eat around it. Like when you go there, you're like, well, that part looks healthy and clean. But so that's always like what I think about when, it's like you're just getting that snapshot in space and time, as you mentioned, where it's like, okay, that's exactly what, we're looking at, but there's, as small as the cells are, there's a lot of, information that could be in other parts.
I like that visual. That's a very good visual. Yeah, you could even think of it like if you like chocolate chip cookie dough, like I do. I'm not suggesting you eat it raw because raw eggs can be dangerous, but if you make like a little cookie ball and it's chocolate chips, you could stick a needle or like a hollow tube, right, into that thing, and you could miss every single chocolate chip. Horror, right? So then if you pulled it out, you would say, oh, there's no chocolate chips in there. So maybe
Right.
you're saying, oh, there's no PDL1 positive cells in there. So that's I like your metaphor. That was
No, I
good.
like that yours too. Abigail, I know you always put us on the spot with like our word of the day after listening to these, resource rich and information rich conversations.
Ooh, there's a word of the day. I'm excited.
Well, maybe our word of the day. Like, what word resonates with you now that you've had I know you just like ran through all these slides. What word resonates that kind of comes out of today's presentation that you think? If you're watching, you can type in your word in the chat. We'll share some of those. But for me, and Abigail always teases me about this too. I never have just one word. There's always like a phrase or something like that. But information overload in like the best positive sense, because I think these are things that we hear, we read them, but again, the more that we hear and talk about them and discuss them, and how concise you were able to present the information, Amy, and have the slides, even though like the formatting was a little wonky, no problem, like really being able to talk through like the basics in understandable terms. So like information overload, but in like the best huggable, like amazing way. So thank you for sharing.
That's so nice. That's actually probably one of the nicest things anybody said to me. Like too much information in a nice, not too much, but a lot of information in a nice, huggable way. I really appreciate that. I think, I don't know, I won't be able to do one word either, but I think know your receptor status, I think is one of the big takeaways. If you are unsure, you can look at your pathology report, but of course you can talk to your doctor, and you definitely should. And if you're ever unsure about something, you can always reach out to, friends and advocates and whatever, but talking to your doctor really is the best way to get that information. Oh, I love that.
Yeah.
Clarity.
Clarity. Excellent. We
Yeah.
also got amazing presentations. And then also another question is just popping up. How do you get these reports?
Oh,
So
that's a great question. That's a great question. Why didn't I talk about that? So there's two ways. The easiest way for me is to go on my electronic health record, which is my chart. So a lot of places use my chart, and you can get in there. If you don't have access to it, I would recommend you do, and you just talk to your doctor's office, and they will give you how to set it up. If you can't set it up on your own, totally understandable. Bring your computer with you or your phone, go to your doctor's office and have them help you set it up and write down the password, because I believe it really is that important. You can then search through test results, and they usually say PATH for pathology. Not always, but that's one way that you might find them. If you're like, don't like computers, don't want to do it, nope, totally fine. Go to your doctor's office and request all of your pathology reports. They have to give them to you. I think they can charge you something reasonable for printing them, but it should be reasonable. And you have an absolute right to all of these, and keeping them in a place where you can find them is also really important. So 2 ways: electronic health record like my chart, or go to your doctor's office and request them. Great question.
Well, this has been amazing. Thank you so much. Abigail just had to pop off. I'm texting her to ask her what her word is, because I know she always puts me on the spot. But this was so lovely, Amy, and thank you everyone for watching and tuning in. And I hope we get to do more of these. I loved the just like, bite-sized 45 minutes, like information overload, that we feel empowered, and we're going to continue the conversation. So tumor markers, biomarkers, molecular, I think coming up soon.
Yeah, for sure.
Right.
Thank you
Thanks,
so much for having
everyone.
me.
So of course, thanks everyone for tuning in.
Totally. Bye.